Good evening, everyone. We thank you for your interest in our mobile integrated health program and hope that you will see needs in the community from our proposal. Mobile integrated health programs have been an asset to the ER system and the hospital system as a whole across the world. In our area, the mobile integrated health venture will be a combination between the EMS department, hospital staff, and it will have multiple phases of implementation. Phase 1 will be the use of our mobile medical unit to go out and have mobile medical clinics without the community. In the 2000s, the Center for Medicaid and Medicare Services created the HRRP. That system fines the hospitals, in essence, by reducing their payments up to 3% on patients that have returned to the hospital within 30 days. Those are for certain issues, including acute MI, knee pain, knee surgery replacement, and COPD, CHF exacerbation. Then COVID-19 hit. We've had increased wait times in the ER and increased visits to the ER by patients using the hospital as their primary care units. Paramedics have been taking on additional duties within the ER and want to bring that out into the community. In 2021, the Decatur Morgan Foundation purchased a mobile medical unit to take out into the community to serve as an early system. They wanted to be able to provide vaccines and some early clinical intervention. In August of 2021, Decatur Morgan Hospital opened a hospital-based ambulance service that started with transports between the hospital only and a backup 911 service. And in October of 2021, the Decatur Morgan Ambulance Service started transporting 911 calls. The mobile medical unit is taken to PR events currently, with 2 of them scheduled per month. In June of 2022, Decatur Morgan EMS began to use the mobile medical unit. Increased call volume for ambulances as compared to previous years has been an issue that was seen, and they are hoping that the mobile medical unit and the mobile integrated health care program can help lessen some of that strain. In October of 2022, there was attendance at the Mobile Integrated Health Summit hosted by the National Association of Mobile Integrated Healthcare Professionals. Literature and statistics were gathered from other MIH programs across the country and were brought in to help create this mobile integrated health program. Mobile integrated health program can be used to reduce wait times in the ER, 30-day readmissions, and indigent care call volume within the city. Statistics are gathered on the number of calls dispatched per fire response area per dispatch code. We want to look at geographical areas within the city that are getting high volumes of calls and see if there is a certain type of call that is being had here. We then want to gather information on the CMS HRRP readmission criteria and compare that to the statistical data that has been gathered on dispatch codes and admissions. Statistics are also gathered for the higher call volumes and what type of call volume is in each geographic area. These are then put together to plan for mobile medical clinics, QRV response to specific dispatch codes, and community education goals. The mobile integrated healthcare program will be a multi-phase program, as we have stated before. Each phase will build upon the other and will be reviewed in a quarterly interval. The first phase is to take the mobile medical units out into the community. They will start with vaccines, easy diagnostics, and early interventions. Phase 2 of the community paramedic program will be community paramedic scheduled emergency department follow-ups. These will be decided upon between the nursing staff and the community paramedic staff and will be scheduled with the patients. There will be 3 to 4 a day at a minimum. Phase 2.5 will be to expand the MMU program. With this, we will be going out more than 1 day a week, hopefully going out up to 3 days a week to different areas within the city. We would also like to start adding in prevention programs and community education on hypertension, COPD, CHF, asthma, and diabetes. Phase 3 of the program is the QRB response to predetermined dispatch codes. And phase 4 will begin specialty responses. We do not know what these specialty responses are at this time because it will be dependent upon our community and the needs that we see from the Mobile Integrated Health Program. So, what evidence is available to show that there are decreased wait times in the ER? We're going to look at how many patients are coming in and what the wait times are. The hospital keeps a very good track of this. They keep track by day, hour, and we'll divide it up into that and see if any of our patients are using the mobile medical unit and the medical integrated health program as opposed to the ER. Is the decrease in wait times financially equitable to the cost of running the mobile medical unit clinics? This will all be determined upon what that decrease is. Is the hospital losing that 3% on readmission rates, or has it balanced out with the cost of the mobile medical unit? It is cheaper to work with paramedics than it is with nurses at the current time right now, and that should help with some of the cost equability. Is there any evidence to show decreased hospital readmissions for the targeted disease? The hospital as well keeps track of all of these and reviews them on a monthly basis. We will look at the patients that we have done the community education with and see if that has decreased any of the responses to readmissions on those patients. What evidence is there to show that the community education classes have had an impact on the decrease in wait times and readmission rates? This one will be harder to track. We will look at the call volume to said patients and see if that is just decreased. By comparing addresses and names to admissions and our mobile medical interventions, we should be able to compare and see if that has had an impact. Have call volumes in the targeted geographic areas decreased? We're trying to decrease indigent care, not necessarily all call volumes. We want to decrease the call volumes for patients that want transport to the ER that could easily have gone to an urgent care or a general practitioner. And what are the thoughts of other healthcare providers concerning the Mobile Integrated Health Program? We have spoken to some of the directors at the Decatur Fire Department, who is another EMS agency in the city, and they are interested in the program. The doctors at the hospital are interested in the program as well. The more we work with this, the more buy-in we hope that we have. The Mobile Integrated Health Program will be an asset to the Decatur Morgan Hospital and the Decatur Morgan community. Starting small and working towards a larger program goal is the best course for this program. Many adjustments can be made by starting small and moving forward. Beginning by enhancing a pre-existing resource decreases the monetary risk. Smart goals will be set at the beginning and reevaluated every 30 days. Phase 1 can begin within the next 90 days. We already have the mobile medical unit. It is already 75% stocked, and we have most of the other equipment to stock it. It is just not on the mobile medical unit at this time. Phase 2 will be a joint effort between both the hospital, emergency departments, and the ambulance staff. We hope to begin it within 180 days of this time. Phase 3 will be a collaboration between the ambulance and Morgan County 911. We hope that we have this one begin within the next 360 days, as refiguring response diagrams takes a little bit longer in some areas. Overall, the Mobile Integrated Health Program will be a benefit to the hospital system and the community because it offers the multiple options for the community to see care received from doctors and other medical practitioners. Does anyone have any questions? Thank you for your time, and we hope to be hearing from you soon.